Chapter 12, Anemias of Disordered Iron Metabolism and Heme Synthesis. Defective hemoglobin production can be due to disturbances in either the heme or the globin portions of the molecule. With the heme molecule, there can be problems with deficient iron, defective iron metabolism, defective porphyrin synthesis. We are going to be discussing those today. And we'll be discussing the problems with the globin chain issues in the next few weeks. Iron is required by every cell in the body, and it must be bound to protein to fulfill all of its functions. Iron itself in an inorganic or ionized form is potentially dangerous. So red cell precursors use most of the imported iron and do not export it. The total iron concentration in the body is about 40 to 50 milligrams of iron per kilogram of someone's body weight. It's primarily found in the red blood cells, macrophages, hepatocytes, and enterocytes. Hemoglobin is a major fraction of the body's iron and encompasses 1 gram of iron per kilogram of red blood cells. Iron in hemoglobin remains in the red blood cell until the cell is removed from circulation. Hemoglobin is released and degraded in the macrophages of the spleen, liver, and bone marrow. Approximately 85% of that iron is recycled, and it's bound to transferrin, which is a transport protein, and delivered to the developing erythroblast in the bone marrow for new heme synthesis. Iron homeostasis depends on the balance of the absorption of iron and the total body requirements. So there's two forms of dietary iron: non-heme iron, which is in the ferric state, or the iron in the 3+ state, and that is present in vegetables and whole grains. Heme iron, or readily available iron, is in the ferrous state, which is the 2+ iron state, and that is present in certain types of red meats and fish. The non-heme iron sources, or the ferric complexes, are not easily absorbed. The gastric acid solubilizes this iron complex, and the low pH allows the transport of these irons across the enteric membrane. The heme iron is more readily available and absorbed quickly and easily to be used for hemoglobin production. When we talk about iron transport and storage, transferrin is the plasma iron transport protein that mediates iron exchange between the tissues. It's a single polypeptide with 2 homologous lobes, and each of those lobes contains an iron binding site that can carry either 1 or 2 molecules of iron. Total iron binding capacity measures the total amount of iron that can be bound by proteins in the blood. And since transferrin is a primary iron binding protein, the TIBC test would be a good indirect measurement of transferrin availability, meaning the amount of transferrin that is able to bind to iron. Serum iron is a concentration of iron determined by the iron released from macrophages to transferrin and the amount extracted from plasma by the erythroid progenitor cells. Transferrin saturation involves the measurement or the percent of how much transferrin is saturated with iron, and this is given in an equation: serum iron divided by TIBC times 100 equals the percent transferrin saturation, which is a good indicator of the amount of iron available for erythropoiesis. As for iron storage, ferritin stores up to 4,500 molecules of ferric iron and is the primary storage compound for iron. It's readily available for erythropoiesis, and it's found in the bone marrow, liver, spleen, and it gives us a really good index of the iron stores within the body. Hemosiderin is iron from hemosiderin that is released slowly. It's not readily available for cellular metabolism. The bone marrow macrophages contain hemosiderin if the iron stores are normal or increased. They're primarily found in the macrophages, and aggregates of iron, lipids, and proteins are found here. So for balancing iron, the daily absorption and loss are small due to the recycling of the remainder of iron. So you lose 1 milligram a day through urine, sweat, bile, and the daily requirements of iron is 1 milligram per day. So we really need to have an adequate source of iron within our foods. Iron deficiency can occur if there is not insufficient dietary intake of iron, if absorption is impaired, if we have increased losses of iron through bleeding, and iron overload can occur if there's absorption abnormally increases, individuals receive a lot of transfusions, or they receive multiple iron injections. So normally in the body, iron is constant in concentration. Humans are unable to excrete it, and the rate of absorption must equal the loss of iron, or anemia will start to incur. Iron deficiency anemia is the most common nutritional deficiency in the world. It's prevalent in countries where grain is a major part of the diet and meat is scarce, or where hookworm infestations are endemic, or if you have decreased availability of dietary iron and chronic blood loss, which develops an increased risk for developing iron deficiency anemia. So, iron deficiency anemia can occur due to the increased demands of iron, poor diet, or malabsorption. So when we talk about blood loss, this is 1 ml of blood loss equaling 0.5 milligrams of iron loss. Chronic blood loss from GI or GU tracts are almost always causes of iron deficiency anemia in males. Intravascular hemolysis, which occurs less often, can occur and can be seen with hemoglobin in the urine, called hemoglobinuria. It can also occur due to malabsorption, which is an uncommon cause of iron deficiency anemia, except for people with malabsorption syndromes, gastrectomies, acute gastritis. So we also have to think about, do we have or need an increased demand, or do we have decreased availability? Iron deficiency anemia is a slow process and can be gauged in 3 different stages. Stage 1 is considered the iron depletion stage. Here, all of the iron stores are exhausted first, indicated by a decrease in serum ferritin. In this stage, you may or may not see anemia, and the red cell morphology is normal. You may start to see an increase in RDW at this point before the anemia develops. In stage 2, we have iron deficient erythropoiesis. So there's insufficient iron to insert into that protoporphyrin ring. So protoporphyrin accumulates in the cell and complexes with zinc to form a compound, ZPP. Now the red cells are going to start to look microcytic. Anemia and hypochromia may be very mild at this stage. Stage 3 iron deficiency anemia. Here, all lab tests for iron status become abnormal. You see a lot of microcytes and hypochromasia within the peripheral smear. This represents an advanced stage of severe iron deficiency. The clinical features are really insidious and take months to years to develop. If there is blood loss, this may occur more rapidly, but there are a variety of abnormalities that appear. So you may see concavity of nails, glossitis, which is a beefy tongue, pharyngeal webs, muscle dysfunction, inability to regulate body temperature, stomach upsetness, or another clinical feature is called pica syndrome. This is an unusual craving for ingested unnatural items, such as phagophagia, which is ice eating, geophagia, which is dirt or clay eating, or even amylophagia, which is starch eating. Iron deficiency infants are probably perform worse in mental and motor development than non-anemic infants. Now let's look at the laboratory features of a patient with iron deficiency anemia. Now in this picture, this is either a stage 2 or stage 3 individual that has a lot of hypochromasia within the cells and a lot of microcytes. Here the MCV might be between 55 and 74. The MCHC should be around 22 to 31, which is hypochromic. The microcytes and an increased RDW are often the first morphological signs. The most frequent poikilocytosis you will see are target cells, elliptocytes, and dicryocytes, which are seen here. When we talk about iron studies, the serum iron is low, transferrin saturation is low, and the serum ferritin level are low in all of the stages of iron deficiency because the iron stores are depleted first. Within the bone marrow, you have mild to moderate erythroid hyperplasia and ineffective erythropoiesis due to the lack of iron present. You have increase in bone marrow activity without corresponding increase in peripheral blood retics. The iron stores, you have absent hemosiderin in macrophages, and sideroblasts are markedly reduced or absent due to the lack of iron. As for therapy for iron deficiency anemia, you have to treat the underlying disorder. Usually you would administer iron and observe the response, which is defined as an increase of 1 gram of hemoglobin in a month, and here you'll start to see reticulocyte response begin at about the 3rd day. Hemoglobin will become normal within 6 to 10 weeks. This condition is anemia of chronic disease. This is also characterized by low serum iron, but the difference between this and iron deficiency anemia is it has normal or increased iron stores. It does not relate to a nutritional deficiency, and most of the anemia that's other than iron deficiency accounts for 1/3 of hospitalized anemic patients. This is caused by a block or a mobilization of iron from macrophages for recycling to the bone marrow erythroblasts. So the iron is there, it just is blocked to be used for making new cells. So you will have a decreased transferrin and an increased serum ferritin with increased iron in bone marrow macrophages. The signs and symptoms are associated with the underlying disorder. So this is rarely severe, but the degree of anemia would correlate roughly with the underlying disease. So the laboratory features of anemia of chronic disease usually present with a mild type of anemia, where you're seeing the hematocrit and the hemoglobins decreased. The red cells in this case are usually normocytic because there is some iron that is available to be made, so the cells look normal, the ones that are made. The RPI is less than 2, and the white cells and platelets are normal. Here is a blood film from a patient with anemia of chronic disease. where you see you have a low hemoglobin count and the MCV is just slightly under the normal reference range. And by telling, you can still see some microcytes in this picture compared to the small lymphocyte that's present. Here we're going to compare the various iron studies that show the difference between iron deficiency anemia and anemia of chronic disease. So on presentation, both conditions present with low iron, but the differences show with the total iron binding capacity, where in iron deficiency anemia it is high, in anemia of chronic disease it is normal or low. The other major distinguishing factor would be the ferritin, where in iron deficiency you don't have any iron stores because it's depleted, so the ferritin level is low, where in anemia and chronic disease the ferritin levels are high because they are present in storage form, they are just not able to be released from those storage forms. The bone marrow, the myeloid to erythroid ratio increases and you have poor hemoglobin production in the erythroblasts. Within the bone marrow, the macrophages have increased amounts of hemosiderin, which can definitely aid in the differentiation as well from IDA to ACD. Anemias associated with abnormal heme synthesis are really the ones that are defective in the enzymes of the biosynthetic pathway that lead to abnormal heme synthesis. Here, the iron incorporation into the protoporphyrin ring is blocked, which increases our iron stores in the spleen, liver, and bone marrow, which leads to our serum ferritin levels being increased. The first condition associated with abnormal heme synthesis is sideroblastic anemia. This results from the mutation that affects the first enzymatic step of heme synthesis due to the formation of ALA. This can be hereditary, congenital, or acquired, and all of these types are characterized by an increase in total body iron, ringed sideroblasts in the bone marrow, in addition to a hypochromic anemia. This is an image of a Prussian blue stained with ring sideroblasts present. So ring sideroblasts are formed from the accumulation of non-ferritin iron in the mitochondria. Here in the mitochondria, with iron, they circle around the erythroblast nucleus. The mitochondria rupture, and then the Prussian blue stain reveals the ringed sideroblast around the nucleus. The hereditary type of sideroblastic anemia is due to a sex-linked type of hereditary condition due to the abnormal synthesis in the first step of the iron in the protoporphyrin ring. Within the bone marrow, you have erythroid hyperplasia and ineffective erythropoiesis. You have increased iron absorption in the gut, which may lead to iron overload that can lead to complications such as cardiac failure or diabetes. The acquired type of sideroblastic anemia can be due to secondarily to drugs or toxins, where here you're seeing a refractive anemia with ringed sideroblast. This can be an acquired stem cell disorder as well, where you have interference with heme synthesis, and the other kind of toxin would be due to lead. So lead poisoning or plumbism in children is usually resulting from the ingestion of lead paint, and in adults, usually from the inhalation of lead or lead compounds from industrial processes. You can also have an acquired sideroblastic anemia due to alcoholism. So alcohol is believed to interfere with some enzymes with hemoglobin synthesis, which leads to the inhibition of synthesis of the pyridoxal phosphate and the activity in the decarbonization of the ring You can also have an association with malignancy, where ring sideroblasts are seen in certain types of leukemias and lymphomas. Here's a blood film, a peripheral film, of a person with sideroblastic anemia, where you see many Pappenheimer bodies or aggregates of iron within those red cells. Anisocytosis is present here, and you may see microcytes, macrocytes, and normocytes within this dimorphic picture. We're also going to talk about and distinguish the iron studies present. Differentiation between IDA and ACD, sideroblastic has a normal or increased amount of total iron, serum iron, with an increased or normal total iron binding capacity, in addition to transferrin saturation and ferritin. Hemochromatosis is a clinical disorder with progressive iron overload that leads to tissue damage. It is not associated with an anemia, but it should be considered when symptoms are present or there is family history of the disorder. Iron studies would suggest iron overload, where you're seeing ferritin being dramatically increased. The excess iron deposits are stored in macrophages, hepatocytes, cardiac cells, endocrine cells, and other tissues that interfere with normal cell function, which can be potentially fatal, and they're classified into hereditary or secondary forms. Hereditary hemochromatosis is an increase in iron absorption in the gut. It has an uncontrolled release of iron from macrophages and enterocytes into the plasma iron pool. Here, excess iron is deposited into the hepatocytes, which increases our iron stores. The most common form of hereditary hemochromatosis is due to a mutation in the HFE gene. The mechanism is unclear, but it results in 3 to 4 milligrams of iron per day that is absorbed from the GI tract instead of the usual 1 to 2. This free iron would accumulate, which facilitates the reactive oxygen species, causing cell death or injury. Most of the excess of the iron is deposited into the liver. So the lab findings would talk about iron overload when ferritin is elevated. Liver enzymes are usually elevated as well, and DNA testing for the mutated gene is needed to be determined. For secondary hemochromatosis, this is associated with many different types of conditions, such as ineffective erythropoiesis and an increase in iron absorption due to beta thalassemias, X-linked type of sideroblastic anemias, or liver disease or excessive iron ingestion. You can also have a transfusion-dependent anemia that also causes an iron overload. The treatment for hemochromatosis is usually a phlebotomy, and each unit removes 250 milligrams of iron for hereditary hemochromatosis. For secondary hemochromatosis, you want to have chelation therapy, which removes the iron specifically from iron, the transfusion-induced type of hemochromatosis. Porphyrias are inherited disorders characterized by a block in the porphyrin synthesis, where abnormal porphyrin metabolism is due to a defect in one or more enzymes in the heme synthesis pathway, which leads to an accumulation of porphyrin heme precursors in the tissue. Large amounts of this is excreted in the urine and the feces. Excess porphyrin deposits result in photosensitivity, abdominal pain, and neuropathy. There are two forms dependent on the primary site of defective porphyrin metabolism, either erythropoietic, where the primary site is the bone marrow, or hepatic, where the primary site is the liver. The pathophysiology of porphyrias are the abnormal enzymes in the heme synthesis pathway within the bone marrow erythroblast. And from here, they are classified into congenital erythropoietic porphyria associated with a hemolytic anemia, or erythropoietic photoporphyria. This is where anemia is rare. So the congenital erythropoietic porphyria has a presence of excessive amounts of type 1 porphyrins, where the defective uroporphyrinogen 3 synthase is defective. So excess porphyrins are deposited in body tissue, excreted in the urine and feces, where intense fluorescence with UV light verifies its presence. The clinical features here are usually teeth that stain brown, you have an enlarged spleen, and you have a mild to severe hemolytic anemia where the lifespan of the red cell is only 18 days. In the peripheral blood, you're going to see a mild to severe normocytic anemia with aniso and poikilocytosis. You'll have a significant amount of polychromatophilia and nucleated red cells. The bone marrow will be erythroid hyperplasia with erythroblasts that are usually fluorescent with UV light. In the erythropoietic protoporphyria, you have an overproduction of protoporphyrin, where you have a defect in the ferroketolase enzyme, leading to excessive protoporphyrin 9, which leaks into the skin and the dermal capillaries found in the skin, blood, and feces, which is not usually present in the urine. Here, you don't really have any significant abnormalities in the blood and the bone marrow, and the cytoplasm of erythroblasts with fluorescent intensity with UV light is there. Red cells, plasma, and feces contain large amounts of protoporphyrin, which is not found in the urine, and you don't have any increase in iron. Table 1217 is a good summary of the conditions associated with abnormal heme synthesis as well as iron metabolism or utilization. Please go over these conditions when you study to discuss the etiology, what you would see in the CBC and peripheral blood, as well as the reflexive tests in the iron studies. Similarly, in this chart is the remainder of the abnormal iron utilization and heme synthesis conditions, so please focus on the etiology, the CBC, and the other iron studies.